This video presentation is going to cover Chapter 53 in your textbook. Mostly we're going to cover osteoporosis, Paget's disease, and osteomyelitis in this section. Again, these are the three topics that we will cover in this presentation. Osteoporosis is a common disorder in the United States. It's a chronic metabolic disease. It's bone loss that leads to decreased density and fractures of the bone. Basically, it's a loss of calcium that causes a loss of density in the bone that leads to pain and injury. If you look back in Chapter 52, if you review how bone is formed, what it is made up of, it can kind of help you understand osteoporosis. Basically what happens is bone resorption, which is the breakdown of bone, and bone building for the first 35 years of your life are equal. So they work together. They're a dynamic process, constantly changing the bone, and they work equally. So bone resorption, bone rebuilding, bone resorption, bone rebuilding. It's equal. After the age of 33, bone resorption is actually increased. It's more than the bone building. So just from age itself, there's more bone destruction than there is bone building. And that can lead to an osteoporosis if there's not preventive measures taken. Women who are at menopausal age are more at risk for getting osteoporosis, and that's because of the loss of estrogen. Estrogen does not build calcium or build bone, but it prevents the loss of calcium in the bone. Lots of other risk factors. Men typically don't really get at risk for this until they're older, until they're in their 70s. And like I said, women are at risk for it after menopause, which is typically from 45 to 50. What's considered primary osteoporosis is the osteoporosis that occurs most often in menopausal women and men older than 75. So that's the more common type of osteoporosis. Secondary osteoporosis is related to other medical conditions. It's really important to note that a hypoparathyroidism can cause osteoporosis, and it's really interesting to look at that because the parathyroid releases something called calcitonin, which has something to do with the reabsorption of calcium. So just know as we go further into this course and we look at the endocrine system, we'll notice that if something's wrong with the parathyroid, then you also have a patient that has low calcium levels, and that leads to osteoporosis. So it's all related, so just make sure you kind of note that and review that. Other secondary causes could be some drug therapy. Corticosteroids are known to cause osteoporosis, and prolonged immobility will also cause and you probably talked a little bit about that in your foundations class about when somebody is immobile for a while, the bone does not absorb the calcium as well. We need to be moving and up and around in order to keep our bones healthy. So those are all the secondary causes. Bodybuild risk factors, the biggest one to note is that it seems that small frame women are more at risk. Women of Asian and Euro-American descent, especially if they have low levels of exercise, they're at higher risk for having osteoporosis. Nutrition risk, of course, if somebody has a poor intake of calcium, they are going to have a low calcium level that will lead to osteoporosis. You have to look at your vitamin D as well. Vitamin D is needed for calcium uptake in the body. And African American women are known to have a decreased amount of vitamin D, so that can put them at risk for osteoporosis, even though it's not their body build or their ethnic descent. It's more their tendency to have a decreased amount of vitamin. A couple other nutrition risk factors. If somebody has a high phosphorus intake, they will have a low calcium level. Phosphorus and calcium are inversely related, so if one is up, the other one's down. A lot of people don't realize that soda, if you drink a lot of soda, it has a lot of phosphate in it. So people who tend to drink a lot of soda, and that's diet soda too, will have low calcium levels because it's the high phosphate levels pushing down their calcium level. Protein, patient needs enough protein as well. If somebody has a low protein level, they are going to be at risk for having a low calcium level. Calcium and protein bind together, and they need each other to be effective. So if protein is low, then the calcium is not going to have the protein to bind to in order to do what it needs to do. Also, as always, high alcohol or tobacco intake will cause somebody to have hypocalcemia, and that could lead to osteoporosis. So knowing all of this is pretty much our role. Is health promotion and maintenance, teaching people what puts them at risk, who's identifying people who are at risk and getting them the resources that they need. It is a big problem in the United States and leads to a lot of money to spend healthcare dollars because a lot of fractures occur, a lot of hospitalizations after fractures may occur. So this is part of our nursing care. So just a picture of how osteoporosis can cause a degeneration in the back and cause a sagging and a decreased height in a patient. Lab tests to test a patient for osteoporosis, of course, is your vitamin D and your calcium levels first, your serum calcium and your serum vitamin D levels. Imaging is going to consist, the most common test used for screening and diagnosis of osteoporosis is your DEXA scan. It's a bone density scan, and actually they're recommending that women after the age of 40 get one to screen if they already have osteoporosis so they can go ahead and get treated. Osteoporosis is like most other disorders. The sooner you recognize it and get it treated, the worse the complications are going to be. So they're starting to recommend that women after the age of 40 start getting the DEXA scan, which tells their bone density. It can go ahead and tell if they're already having a loss of their bone density. DEXA scans are pretty harmless, really not much of a prep for it. Basically, the patient just has to undress and remove any metal objects. There's no post-op follow-up special care, really. They can go home, and then they just need to discuss the results with their caregiver. The most common complication of osteoporosis is fractures, frequent fractures that can really limit a patient, especially an elderly patient, if they end up getting a fracture late in life. So another test, of course, that would be appropriate for making sure someone doesn't have a fracture, or if they suspect a fracture in a patient, then they would do x-rays. So that's some other imaging that the patient may have. So all of this leads us to what we do as a nurse to take care of a patient who potentially has osteoporosis or is at risk for osteoporosis. It's basically teaching them about good lifestyle. You're going to have to avoid the alcohol, a lot of caffeine, avoid the soda, get good exercise. Of course, all mobility helps your bones, makes your bones stronger. Get out and walk. Get out, a couple times a day. Get out and take a walk outside. That's always going to help somebody make their bones stronger. Teach them about all the screenings, especially if there's somebody who's reached a woman that's reached her menopause. And may see if they understand that they're at risk for osteoporosis. What is your nutritional intake? Test them to see if they have a vitamin D deficiency. Ask them if they've had any frequent fractures. Really just talk to them about their diet. If there's somebody it sounds like they're not getting an adequate diet, not getting enough calcium, then maybe they need to be on calcium supplements, which leads us to the drug therapy. Drug therapy for osteoporosis begins with supplements. Calcium supplements should always be given before meals. Encourage the patient to drink fluids if they don't have any contraindications for it. Encourage them to drink fluids while they're on calcium supplements. It helps to absorb and it helps to prevent any kidney stones that could be related to calcium intake. The next type of treatment for osteoporosis are the biophosphates. The biophosphates work by slowing down the resorption, which means the bone destruction, so that's how they assist in the treatment for osteoporosis. The important thing about biophosphates is there's a lot of instructions involved with them, and the patient has to be able to follow these instructions in order for this drug to be effective. Basically what happens is they have to take these way before their meals. Calcium supplements can be given with food, but it's good for them to sort of take it like right before their food. And then as they take their food in, then it's absorbed better. The biophosphates, they have to take it typically 30 minutes before they eat anything, so that's a little different about that. And they typically have to sit upright for that entire time and remain upright for an hour after the administration of the medication. And this is because it causes a lot of GI upset. It can cause esophageal ulcers and gastric ulcers. It's very, very irritating to the stomach lining. So a lot of instructions involved. They have to take it 30 minutes before a meal. Usually in the morning is the best time to give it. They have to drink a full glass of water, and then they have to stay upright for 30 minutes to an hour after the administration of the medication. These are your biophosphates. We're talking about Fosamax, Actinol. The one thing about them, though, is they are only needed to be given, a lot of the newer ones, they only take it like a couple times a week. Boniva, some of the newer ones are getting them down to like where they only have to take them once a month or once every 3 months. Boniva is actually IV. They can give it IV, so every 3 months. So a lot of different ways these medications can be given. Calcitonin is that hormone that is secreted it's a thyroid hormone, and it can decrease the osteoclastic activity as well. So calcitonin can be a treatment for osteoporosis. Calcitonin is sub-Q, or it can be given intranasally. So most people prefer to do it in their nose. It's a little easier to do. They're more compliant. They can build up a tolerance to this drug after a couple of years, so they may have to take them off for a little while, like a month or so, and then put them back on it later. But typically it can be an effective drug for osteoporosis. So Paget's disease is a little bit different from osteoporosis, and the fact that it is a chronic metabolic disorder. Basically, the bone constantly is going through an excessive amount of breakdown, and then it goes through an excessive amount of building back up. So you have the osteoclastic activity, and then you have the osteoblastic activity, and it's just kind of gone haywire. So basically what happens is the bone structurally is disorganized, and it can be weak because of this disorder of the buildup and breakdown of the bone. This disease is second only to osteoporosis as the most common bone disease in the United States. It affects about 1 million people in the United States. It's seen more frequently in people older than the age of 50. Those with European heritage have a little bit higher risk for having it. The risk increases with age, and actually men are affected twice as often as women. So that's a big difference for Paget's versus osteoporosis. So a patient with Paget's disease presenting to a medical office would have complaints of bone pain, maybe some common fractures. Pain typically occurs like in their hip or pelvis. They can't have it in any bone in their body though, actually, and sometimes if it affects the small bones, it can really cause some issues, especially like the bones of the ears. They can have hearing loss related to it. So lots of different manifestations of this disease. The big difference with this and other of the musculoskeletal is that it can cause the bone deformity. So that's what you would look at in a patient if you suspected it, is to look at you could tell any bone deformity. Paget's disease can actually lead to maybe a cancer. It is rare, but it can happen, so it is something that they will be monitored for if they're diagnosed with Paget's disease. The physician will monitor them for any signs of developing any kind of an osteogenic sarcoma, especially in their older age. There's a few labs they can do to diagnose Paget's disease. Typically, an x-ray is what's going to diagnose it, and that's going to just show them the characteristic changes in the lesions, the enlarged bones, the deformed bones is what they're going to see on x-ray, and that's going to help them make the more definitive diagnosis for that. For drug therapy, you're going to give biophosphates. That's going to be your first line of treatment. And if you remember, the biophosphates protect the bone from too much resorption, which is the breakdown of the bone. If the oral biophosphates are not effective, they'll switch them to the IV biophosphates that are available now. People with Paget's disease also are going to need some NSAIDs or pain medication. Typically, they'll start out with NSAIDs for the anti-inflammatory effects of them. Just remember all of the side effects that NSAIDs can cause. Make sure you watch for GI upset, any signs or symptoms of a GI bleed. Calcitonin can also be used for a patient with Paget's disease. And again, it reduces the bone resorption for them, so it could help kind of decrease that craziness, that crazy breaking down and rebuilding of the bone, and hopefully get them more of an equal bone resorption and decrease the pain. A patient with this disorder is going to have anywhere from a low calcium level to a normal calcium level to a high calcium level. It's really going to depend. So the provider typically monitors their calcium level closely and then treats them accordingly. If they have a low calcium level, they might go ahead and give them a calcium supplement. Really just depends on the patient's response to the disorder. Nursing care is going to be, of course, educating the patient about their disorder, teaching them to try to continue to be mobile as possible. That's gonna be one of the best things for them. However, they are somebody that is in pain, and they are somebody that has compromised bone formation. So it's not going to be real high contact sports. It's going to be walking. It's going to be low contact, low impact exercise. Physical therapy is going to be a good assistance with this kind of treatment for a patient. Make sure they have a diet that has adequate calcium and vitamin D for them, a diet that's going to promote bone health. You can also find them resources in the community that can help them work through this disorder. Osteomyelitis is just essentially an inflammation or infection of the bone. It can come from a couple of different ways. Exogenous is if it comes from the outside of the body, such as an open fracture if they're in a traumatic accident. From an opening of a compound fracture, that can cause an osteomyelitis. It can be endogenous if they have something in their bloodstream, if they have a septic patient that has serious bacteria in their bloodstream, it actually can get into their bone and cause an osteomyelitis. Osteomyelitis is a pretty serious infection. It's difficult to treat. It can cause damage to the bone. The longer it goes on is untreated. It can cause loss of function, can cause a need for an amputation. It also can lead to cancer in the bone. So it's a very serious condition that needs to be identified and treated immediately. It's all going to be treated depending on the type of osteomyelitis it is, where it came from, what was the cause. That's how it's going to determine treatment. It can be acute or chronic. All of that, like I said, is just going to determine what the treatment is, how it occurred, where it came from is going to be the leader in how we treat it. Hematogenous osteomyelitis is the most common kind, and that is the kind that is going to come from something that's in the body. Urinary tract infection is a common vessel for this type of osteomyelitis. Signs and symptoms of osteomyelitis is going to be a high fever. Typically, it's greater than 101. And then you're going to get the typical signs of an infection. You're going to get redness, hot, swollen, a lot of pain to the area. If you look on page 1132, there is a chart that is going to give you the signs and symptoms of acute and chronic osteomyelitis. They're a little bit different in the way that a patient with acute, of course, is going to have the higher fever. They're going to have the more signs and symptoms, the more swelling, the more redness than the patient with a chronic osteomyelitis. You're going to see more of the acute symptoms. They're going to have more of an elevated white count. They're going to have the ESR, which is the erythrocyte sedimentation rate, which indicates an inflammation in the body. That's going to be elevated in a patient with osteomyelitis. And basically, the treatment for this is you have to identify where it came from, what the germ is, what the bacteria is, identify it, and treat it appropriately. Typically, it's IV antibiotics, and it's going to be probably pretty long-term IV antibiotics. It's going to be like a 3-month run of antibiotics for this. Basically, they'll get a PICC line and probably go home and have home care come and help them administer that. So they're going to have a lot of education on how to teach, how to be compliant with that. Because like I said, it can be a really dangerous infection and can lead to the loss of a limb if they're not careful. So they need to be compliant with the treatment of this. They will also need treatment for pain, so just be aware, they're not going to be they might be off work if it's somebody who works, so it's going to be a little bit debilitating for a while, but they need to be highly encouraged to be compliant with the treatment for osteomyelitis. Okay, we're going to take a quick look at bone cancer. There is benign, of course, and malignant tumors. As we talked about in Module 3, can be primary or secondary. Primary tumors, of course, are going to be the ones that originate in the bone. And then your metastatic lesions are going to be something that has metastasized from another site. Ironically, radiation therapy can put a patient at risk for having bone cancer. So if somebody's been treated for another type of cancer, it can put them at risk for bone cancer. So it's kind of an ironic twist. Most bone cancers are metastatic in origin. The primary ones are typically an osteosarcoma. That's the most common type of a primary malignant bone tumor. Most of those do occur like in the larger bones, which is the distal femur and the leg. Those are typically diagnosed. Patient will complain of acute pain and swelling in an area. And these typically do occur, primary tumors and bone cancer typically occur in younger people, 10 to 30 years of age. And they'll just come in and complain of an acute swelling and pain to a site. And usually really what happens is they'll think maybe they have a fracture of some kind, but usually the patient cannot identify any injury, like a fall or anything like that, but they'll have a lot of pain and swelling. So they'll x-ray them, and maybe they can see the tumor on x-ray, and then they send them to MRI, and that's how those are typically diagnosed. They do occur twice as often in males. And again, they're common with patients who have Paget's disease. The metastatic cancers are the ones typically coming from the lungs, prostate, breast, or kidney. They say these are the bone-seeking cancers, so that's typically where they're going to come from. Treatment for the patient with bone cancer is going to depend on the origin of the cancer, where it came from, how much it's spread. Again, it could be chemo and radiation. There can be some surgical intervention. They may be able to remove the tumor depending on how much it's advanced, of course, just like most of your other cancers. And post-op surgery for them is going to be, somewhat similar, and it's going to depend on the exact surgery that they have, especially what area it's going to be. But, it's going to be your typical, monitoring for pain and things like that. There are some bone tumors that can actually be benign, and typically they end up having to be removed, especially if they're in somebody that's younger of age and still growing, because they can disrupt growth. So that's typically why they have to, that's usually a surgical intervention for them, and just because it's disrupting the normal flow of everything. So they're not really spreading anywhere, but they are causing pain and discomfort and disrupting the normal bone growth. So that's why they'll try to go in there and remove them with surgical intervention. So other common musculoskeletal disorders just to have mentioned, and these can be related to a lot of these other things that we mentioned, contractures, pain, and mobility impairment. So you just need to think about, as a nurse, what we can do to prevent contractures. Anytime anybody has a musculoskeletal disorder, they're going to have problems with mobility, safety, falls, daily living, activities of daily living, getting adequate intake. They need good nutrition in order to promote healing. Pain control is always going to be an intervention that's going to be important for the nurse to do, so just kind of think about those for that. This concludes this portion of the Module 4 presentation. Please feel free to view the case study that follows in order to assess your learning.